Hello, everybody. I'm happy to join fourth year medical student in the serious lectures in the cardiovascular disease. Our title today is the lecture in the constrictive pericarditis and pericardial fusion and tamponade. This is the key answers of the previous test, of the previous lecture. If someone asks, we discuss chronic constrictive pericarditis and pericardial fusion in the previous lecture, but we will repeat and concentrate in certain point in this mini lecture for three reasons. Firstly, constrictive pericarditis and restrictive cardiomyopathy have similarities in clinical presentation. Secondly, if we differentiate between them, so constrictive pericarditis have a definitive treatment surgical by removal of the pericardium, while the restrictive cardiomyopathy have no treatment. Thirdly, the pericardial tamponade is emergency. If we have high index of suspicion, undiagnosed might save a life. Let us go to the constrictive pericarditis. Is a chronic constrictive pericarditis a chronic inflammatory process that involves both fibrous and serous layers of the pericardium that can lead to the pericardial thickening, compression, or constrictions of the ventricle, and this resulting in impairment in a diastolic filling and a venous return and reduce, lastly, the cardiac output. Causes idiopathic is most common in developed nations, while radiation, post-surgical infection, especially suppurative, chronic, like TB, is the most common in a developing nation. Neoplastic, autoimmune connective tissue disorder, uremia, post-trauma, sarcoid, methylsergide therapy. Now it's rare because of limited use of this medication. Implantable defibrillator patch. So constrictive pericarditis rarely develop, as we said in a previous acute pericarditis, an episode of idiopathic pericarditis. More likely to develop after subacute pericarditis with effusion that evolve over several weeks. More frequent again after purulent bacterial or the tuberculous pericarditis. So, in summary, the causes idiopathic TB, most common in the underdeveloped countries, radiotherapy, cardiac surgery, connective tissue disorder, dialysis, and bacterial infection. So it's fibrinous thickening, adhesion, calcifications of the pericardium. Most common etiology, we mentioned three: TB in developing countries, while idiopathic in developed countries, and post-pericarditis of any etiology. This is a gross appearance of how thickening of the pericardium with calcium there, and a lot of fibrous tissue and adhesion. Incidence of pericarditis in patients with pulmonary TB range from 1 to 8%. Some texts is 1 to 2%, but it is near that clinically is a 1 to 8%. Physical finding, fever, pericardial friction rub, and hepatomegaly. TB skin test, usually positive. Fluid smear for TB, if we aspirated, often negative. Pericardial biopsy, more definitive diagnostic. On physical finding on constrictive pericarditis, jugular venous pressure increase and jugular is prominent, X and Y descent. We increase with inspiration what called cosmal sign. Lungs, possible pleural effusion, possible pleural effusion. Heart, diastolic pericardial knock. Abdomen, ascites, pulsatile liver, right quadrant abdominal pain, extremities, peripheral and pedal edema. And during catheterization, find in the right and left heart pressure are measured simultaneously equal. I mean right and left ventricle diastolic pressure are elevated but nearly equal. Equalization and may show the classical square root signs. Right atrial pressure has a steep X and Y descent and may rise during inspiration, what called cosmal signs. This is a square root and equalization of pressure in the both restrictive and constrictive pericarditis, dip and the plateau, or square root sign. And clinically, the patient, the fatigue, hypotension, tachycardia, elevated JVB, cosmal sign, pericardial knock, and ascites and edema. In a diagnosis, it's important to do chest X-ray. Lateral is better. Calcified pericardium on X-ray. Imaging thickening of pericardium. CT scan, MRI is quite sensitive. Cardiac catheterization, as we said, these 3 points. Elevated equalization diastolic pressure, restrictive filling, RV dip on the plateau and square signs, prominent YX descent, and RV pressure tracing. This is important, don't forget, it's calcium there in the pericardiums. It's always coming through on examination. And this is the calcification in chest X-ray, chronic pericarditis. And this is the calcium in the pericardium. And as we know from the previous lecture, clinically, how to differentiate is difficult, but there is some hint that this is a constrictive pericarditis. History provides an important clues. Constrictive pericarditis, as we said, history of TB, trauma, pericarditis, collagen vascular disease, and this is a collagen vascular, as we said in the previous lecture, collagen. Restrictive cardiomyopathy, amyloidosis, hemochromatosis, and mix in the intestinal, mediastinal radiation, and cardiac surgery. Management of constrictive pericarditis. With exception of patients with a transient constriction, surgical pericardiectomy is the definitive treatment. As we say, in the reverse of the restrictive cardiomyopathy, no treatment, only palliative. Patient with major comorbidities, severe debilitating disease, radiation-induced, as we said, it's a poor prognosis because underlying malignancy, all these are relatively contraindicated for the surgery. Medical management with diuretics and salt restriction. Because of sinus tachycardia is compensatory mechanism, that's why beta blockers, calcium channel blocker, it's better to slow the heart should be avoided. In patients with atrial fibrillation and rapid ventricular response, digoxin initially and then put a beta blocker and calcium antagonist. Tuberculous constrictive pericarditis, pericardiectomy should be performed early and as radically as possible. And combination of the anti-TB and surgery yield gratifying and a very beneficial result. Tuberculous pericarditis, as we said, in 1 to 8%, now mentioned 1 to 2 in different references of all patients with TB, by direct extension from mediastinal lymph node, and occasionally by hematogenous spread, or by contagious spread from the myocardium. Triple therapy for 9 months, and sometimes we need surgery. In patients in whom pericardial effusion persists or recurrent despite use of anti-TB drug for 3 months, added corticosteroid may be useful, and adjuvant treatment. And a pericardial effusion, as we said from the previous lecture, the pericardial stretch and effusion, that if it's slowly and stretch enough, even large ones may not produce hemodynamic change. However, if it is rapidly accumulated, even small ones, effusion can cause tamponade. Effusion, or that the fluid is a serous, transudative, if a heart failure, suppurative or biogenic infection with cellular debris and large number of leukocytes. Hemorrhagic occurs with any types of pericarditis, especially with infection and malignancies. There is a serosanguinous types of the pericardial effusion. The tamponade, as we said previously, is elevated intrapericardial pressure more than 15 millimeter of mercury that restrict venous return and ventricular filling, resulting in a decreased stroke volume, pulse pressure, and increased heart rate, and the venous pressure increase too. Most common complaint, dyspnea and decreased exercise tolerance. Common symptoms, chronically, weight loss and pedal edema and ascites. Physical finding, as we said, tachycardia, low systolic blood pressure, neuropulse pressure, pulsus paradoxus, neck vein distension, and distant or muffled heart sounds, right upper quadrant pain. This, as we said, peaks triad by hypotension in acute cardiac tamponade, distended jugular veins, and the indistinct or the muffled heart sound. Subacute or chronic forms of the cardiac tamponade, venous pressure increase, congestion of systemic circulation, cosmal signs positive. The peak triads described since 1935 by thoracic surgeons Cloud's peak. Three feature, as he described, decline in the systemic arterial pressure, now it's mentioned as shock, elevation in systemic venous pressure, distended neck vein, and a quiet heart. Chest X-ray usually require more than 200 ml to be more obvious, so small amount difficult to be differentiated from the pericardial and the pleural fusion. Cannot be distinguished between pericardial fusion and cardiomegaly. Echocardiography is standard for diagnosis pericardial fusion. Convenient, highly reliable, cost-effective. False positive A-mode in the false positive in M-mode, not 2-mode, left pleural fusion, pericardial fat, tumor tissue, and pericardial cyst. In the non-compressing effusion, asymptomatic usually, unless they are large enough to compress adjacent organ, dysphagia, cough, dyspnea, hoarseness of voice, hiccup, abdominal fullness, and nausea. Diffuse or slow in ECG, diffuse or low voltage. Amount depends on amount of the fluid, which is not conductive electricity, and electrical conductivity of the fluid is poor. Electrical alternance, it means alternating amplitude of a QRS complex. This is produced by heart swinging motion. And also seen, this is electrical alternance in paroxysmal supraventricular tachycardia, hypertension, and ischemia. So it is cardiac tamponade is decompensated cardiac compression from increased intracardiac pressure. Early stage, mild to moderate elevation of central venous pressure. In advanced stage, increased intrapericardial pressure, decreased ventricular filling, decreased stroke volume, hypotension, impaired organ perfusion, elevated JBV venous pressure, and a paradoxic pulse. Pulsus paradoxus, we mean by it, just to remind you, an exaggerated drop in blood pressure within inspiration, more than 10 millimeter of mercury dropping of blood pressure. Tamponade without pulsus paradoxus. We have a tamponade but no pulsus paradoxus, an atrial septal defect, aortic insufficiency, left ventricular hypertrophy with the increased left ventricular and diastolic pressure. There is a pulsus without tamponade, pulsus paradoxus without tamponade, chronic obstructive airway disease, right ventricular infarction, pulmonary embolism. Put this in your mind, please, and remember. Pericardial effusion, highly echocardiography is a gold standard, as we said, investigation. Pericardial effusion, highly reliable. Cardiac tamponade is the right atrium and right ventricular diastolic collapse. Reduced chamber size, distension of the inferior vena cava, exaggerated respiratory variation of mitral tricuspid valve flow velocities. And this is in a previous lecture, pericardial effusions and the water bottle appearance. While the clear long field, it's helpful to diagnose and differential diagnosis from heart failure. And this is the short axis view echocardiography, 2D echocardiography, and this is the what called chamber size decrease and collapse of RV, right atrium and the right left ventricle there. And this is long axis, parasternal long axis view. This is amount of the fluid and the chamber size decrease and collapse of the right atrium. This is what mean by the low voltage and the pulsus alternance from high low of a QRS complex. This pulsus alternance is quiet. Here is this is low, this is high. In general, it's low voltage. Diagnostic tab, diagnostic tab usually not indicated in the pericardiocentesis usually, rarely have a positive cytology of infection that can be diagnosed. But therapeutic range is the highly important, indicated for significant elevation of central venous pressure. Balloon dilatation of a needle pericardiostomy, sometimes used to do a pericardial window, or subxiphoid surgical pericardiostomy, video assistant thoracoscopy with localized pericardial effusion, and intralateral thoracotomy with the parietal pericardial resection, sometimes they do. This is an acute cardiac tamponade. The treatment of cardiac tamponade is a drainage of pericardial content, preferred by needle paracentesis with the use of echocardiographic or another types of imaging such as fluoroscopy or CT scan. Medical management of the cardiac tamponade, of acute cardiac tamponade, include inotrope support with or without vasodilator. It's relatively controversial and aimed to supporting compensatory mechanism to reduce the elevated vascular resistance. So use of this positive inotrope like dopamine administrators is the reverse the hypotension. This theoretically is the ideal. During tamponade, however, endogenous inotrope stimulation of the heart is often already maximal. About giving IV fluid and volume replacement, increasing the volume may help only in patients with hypovolemia, since patients with the normovolemia and hypervolemia volume infusion may be harmful and not beneficial by increased intracardiac pressure as well as heart size, which in turn increase pericardial pressure, further reducing elimination the low transmural myocardial pressure supporting the circulation. This is the subxiphoid, and in the subxiphoid in the direction of the left shoulder can put a needle under fluoroscope, echocardiography, or CT scan, and put a catheter there, and sometimes do a window, and put a big tail catheter in case of aspiration of hemopericardium due to the trauma or due to the coronary dissection in the cath lab. Thank you for the active participation.